USMLE Step 1 Microbiology is going to start today on our channel from today onwards. And these are a set of questions that I created when I was myself preparing for the exam. Now, these questions are signifying high yield important topics. But there is a system that you need to follow in order to take the most out of this QBANK. And that system is that you need to first understand that these questions do not depict the reality. The same questions do not appear in the exam, right? The same as it is question will not appear in the exam. They will not ask directly about the staining techniques, but they would incorporate their knowledge in the STEM and then ask you an associating high yield factor. So in order to answer that part of the question, you need to know that what is the stain or what is the small information, the bits of information that is actually hidden in the text in these big textbooks that describe microbiology as a whole. So you need to remember that text. Now, better than me just presenting a table in front of you and telling you to regurgitate that table and remember that and commit that to memory without any context, that would be difficult for you as a student. So today we're going to remember that information specifically, which is not asked directly in the exam, but will help you answer many of the important questions and it will help you understand many important concepts. So you have to use this question bank in order to learn that information, in order to help you memorize that information, which is difficult to memorize in itself. And also this small information is not presented question-wise in many important and famous question banks. So by using this as a template, you can actually learn about this and then practice this so that you don't get confused and you have a one-stop material to practice on. All right, so we're going to start USMLE Step 1 Microbiology. So I'm going to highlight the important clues and you have to solve this question on yourself first, okay? So there's a 28-year-old man presents with chronic low-grade fever and unintentional weight loss, an intermittent non-bloody diarrhea for 3 weeks. And he returned from a hiking trip from rural Europe. Testing reveals iron deficiency anemia and hypoalbuminemia. And a small bowel biopsy shows foamy macrophages, the lamina propria, at stain magenta. Which of the following special stains was most likely used to support this diagnosis? Now you need to understand that, first of all, let's break down the clues. So it's important to remember the age. Now we're talking about microbiology, so age would not matter that much, but in systemic pathology and in other areas in pharmacology also, age matters a lot. So you have to concentrate on the age. What they're saying is that he is having a low-grade fever and has weight loss and has a non-bloody diarrhea. And he's back from a hiking trip and he has iron deficiency anemia and foamy macrophages. So there is really no concept in infectious in microbiology. There is really no concept that you need to understand. You just have to remember the association and the pattern that is presenting. Magenta is just basically a color. It's a kind of a color, maroonish type of color. So you need to remember, you don't really need to concentrate on this. This is not important. But other clues are, so this constellation of non-bloody diarrhea, weight loss, and a history of travel history given in the question, with iron deficiency anemia with foamy macrophages, this basically shows Whipple disease. So this sentence is quite important. the foaming macrophages in the lamina propria. This is basically, you can say, pathognomonic for Whipple disease. So Whipple disease uses periodic acid stare, and it's basically known as PAS positive macrophages in the small bowel. PAS positive is periodic acid shift stain positive macrophages. So the foaming macrophages that they described here are basically visualized by this stain. And these macrophages are specifically found in Whipple disease, in Tropharema Whipple. This is basically a malabsorptive disease. So it can lead to many deficiencies, and can also lead to iron deficiency anemia. So this, you have to understand that foamy macrophages in the lamina propria are pathognomonic for Whipple disease, which can be visualized. The bacteria can be visualized by periodic acid shift state. All right. Okay. So, which of the following stains is most appropriate to visualize this organism? CSF. So this should give you some clue that we're specifically talking about the CSF. So your 36-year-old man has HIV and CD4 count is very low. Presents with worsening headache, photophobia, and blurry vision. For examination, is febrile, somnolent. Lumbar puncture reveals elevated opening pressure, low glucose, and encapsulated yeast on bed mount. The important things that you need to concentrate on this question is that, first of all, you need to remember that this CD4 count, which is less than 200, can lead to a variety of problems. One of them being the increase in number of the opportunistic infections that occur. So you have to remember that CD4 count less than 200 can lead to many problems and many infections. So this infection is one of those infections. And you can see that they have said that this is a yeast, right? A yeast that is causing somnolence, headache, photophobia, and blurry vision. So basically a fungus that is causing encephalitis or types of symptoms that is related to the brain. It's related to the brain. So HIV patient and CD4 count less than 200, or cryptococcus can occur regardless of the CD4 count, but we will discuss this is actually cryptococcus. So HIV patient with meningitis / encephalitis kind of symptoms with a low CD4 count is mostly cryptococcus until proven otherwise. So that is cryptococcus until proven otherwise. Right, so it basically has this main stain which is known as Indian ink stain. And mucicarmine stain is another option. This is another option. You need to remember both of them because both of them are asked in the questions. Indian ink stain is very important. This is very high yield. This is pathognomonic for cryptococcus. Neoformans and mucicarmine stain is also important. You need to remember this. One more high yield fact about this is that people mostly confuse cryptococcus with cryptosporidium. And both of them, they occur in HIV patients. But there's a difference. Cryptosporidium causes diarrhea, watery diarrhea. All right, it can sometimes cause bloody, but this specifically causes watery diarrhea, which is the most common cause of diarrhea in HIV patients. And cryptococcus is limited to the brain, so it causes meningitis and encephalitis. So you need to remember this distinction. All right, can't speak for some reason. You need to remember this. All right, so which of the following stain is more suitable for identifying the causative organism? So this more method of reading the question's last line before reading the entire question is also a useful method. So you can try that. So 31-year-old woman presents with recurrent episodes of high-grade fever, chills, and fatigue. She recently returned from a 2-month stay in Nigeria. On examination, she's pale and has mild splenomegaly. A peripheral blood smear is obtained and reveals intra-erythrocytic ring forms. Which of the following stain is more suitable for identifying the positive organism? So, right off the bat, the most important clue in this question is intra-erythrocytic ring forms. You can find these in basically two, I would say, pathologies. One is malaria and the other is babesiosis. So we can find these in these two pathologies mostly. It can exist in other infectious diseases also, but mostly that is tested is in these two forms. So when you look at this word, your first clue is looking at this word, right? Number one is looking at this word. To remember this word, intraerythrocytic ring forms. Second, you need to identify what place have they visited. So this is a malaria endemic place, Nigeria. If it is a malaria endemic place, then most probably the diagnosis is malaria. If it is not a malaria endemic place and the person has not traveled outside the US, United States, they say that the person has not traveled outside the United States, then the diagnosis is most probably babesiosis. So you have to keep this distinction in mind. All right, babesiosis is basically American malaria, if you can call it. Easy for you to remember. And then we need to look at the symptoms. So high-grade fever, chills, and fatigue. This is your third. And splenomegaly can be a fourth clue because there is destruction of the RBCs. So splenomegaly can be your fourth clue. But these three things you have to remember. Number one, intraerythrocytic ring forms. Number two, the place that they have traveled. Is it malaria endemic or not? And number three, what are the symptoms? High-grade fever, chills, fatigue. These symptoms basically specify that there is some kind of toxemia in the blood. And why do patients have splenomegaly? Because the RBCs are infected. So the RBCs that are infected are primarily going to be destroyed in the spleen. So there will be more RBC destruction, and which will subsequently lead to the enlargement of the spleen, leading to splenomegaly and mild form of anemia. So malaria is caused by the Plasmodium species, and it is visualized by GM sustain, which is important for you to remember. This is very important. GM sustain. It can be also visualized. The intraerythrocytic ring forms can be visualized through the blood smear, but the Plasmodium species itself can be identified by GM sustain. And it is also useful, the GM sustain is also useful for trypanosoma, chlamydia, and rickettsia. This is a very high point. You need to remember this. So both of these sentences are high. You need to remember these. Okay. Right. So moving on. So the following is the most sensitive screening method for detecting this pathogen. 41-year-old man with HIV presents with subacute shortness of breath and dry cough. The chest X-ray shows bilateral ground glass opacities and bronchoalveolar lavage is formed. Microscopy reveals cyst-like organisms that do not stain well with gram stain. So the following is the most sensitive screening method for detecting this pathogen. So again, you need to remember that, first of all, it is an HIV patient. Second of all, you need to understand that these organisms are affecting the pulmonary system. So you need to make this association that what organism affects the pulmonary system in an HIV patient, and they are not staying well with gram stain, right? So number one, HIV patient whose pulmonary system is affected. Clue number two is bronchoalveolar lavage will be most probably done in this patient, in these kind of patients, and chest X-ray will show bilateral ground glass appearance. Bilateral ground glass appearance or interstitial opacities. That is what is going to be mentioned in the question. So this likely points towards pneumocystis. These clues you need to remember. And it is pneumocystis. So ormine rhodamine stain that is used for pneumocystis. It is a quite pathognomonic organism in itself. The presentation is quite pathognomonic. It is an acid-fast organism. That is why it does not stain well with the gram stain that they had mentioned in the question. So you need to remember this. The stain, ormine rhodamine stain. This is important. This is high yield for pneumocystis. This presentation is very important. This is how mostly pneumocystis cases will present. Either they will say bilateral ground glass opacities or interstitial opacities. Bilateral. All right. So, which of the following organisms is most likely responsible? Peripheral blood smear reveals intracytoplasmic morula within the monocytes. So let's read from the top. 30-year-old man presents with fibromyalgia headache. He had a camping trip in Arkansas. He reports multiple tick bites. The exam shows no rash. Blood culture and ground smear are negative. Intracytoplasmic morula with monocytes. So again, a pathognomonic presentation, highly specific for one organism. Number one, the first clue is this sentence: intracytoplasmic morula within monocytes. Second clue is that he had multiple tick bites. So any description of a tick bite or any hint towards that or any hint of a camping trip in mountainous regions such as Arkansas, and if you could call that as a separate clue or clue number three, that there would be no rash. So these three clues would lead you to the diagnosis of Ehrlichia, right? Now, tick bites can also result in Borrelia. Borrelia can also result, but Borrelia would mostly result in a rash. It has erythema migrans, if I'm remembering correctly. It is a bullseye rash. It is a bullseye kind of rash like this. So it has a rash, and this patient has no rash. So Borrelia will not be the answer. And the other organisms, they are not related to tick bites, so they can't be the answer as well. So Ehrlichia is the answer. Ehrlichia is the correct answer. It is an intracellular bacterium which invades the monocytes. It is tick-borne and ground stains negative and diagnosed by PCR. So these are important points that you need to remember. So diagnosed by PCR and obligate intracellular bacterium invading monocytes. It's gram stain negative, although bacteria, but gram stain negative due to it being intracellular, right? So it is gram negative. So It can mimic sepsis or meningeal encephalitis if it is severe enough. It can mimic these pathologies. Ehrlichiosis is much like Rocky Mountain spotted fever, because Rocky Mountain spotted fever is also transmitted by the ticks, and a mountainous region will also be mentioned in a Rocky Mountain spotted vignette. But a way to uh, diagnose it is that Rocky Mountain spotted fever would have a rash, right? And ehrlichiosis has no rash. So Rocky Mountain spotted fever has a purpuric rash, right? Has a purpuric rash, has a small petechia or purpura throughout the body. Otherwise, they are both are the same. You can see both of them have thrombocytopenia, both of them have leukopenia, and both of them have fever. So Rocky Mountain spotted fever and ehrlichiosis present as the same. Both have fever, both have leukopenia, both have thrombocytopenia. The difference is that Rocky Mountain spotted fever has no rash, has a rash, and ehrlichiosis has no rash. Rocky Mountain spotted fever has a rash, and ehrlichiosis has no rash. And one thing else is that one similarity is that both of them would have a mountainous region in their presenting history. So yeah, that's basically it. Both of them are mostly considered the same. So you need to remember both of them. These are very important organisms. Rocky Mountain spotted fever, and ehrlichiosis. These are mostly the same. Okay. So I guess that's it. Hopefully you liked it and followed along. Thank you for watching.